let me try that again, from the International Prehospital Medicine Institute. And I'm here with my partner, Greg Chapman. We'll let him introduce himself in a minute. In my background is I was fire chief, paramedic, trauma nurse specialist, and since retirement, we've been working full-time in the International Prehospital Medicine Institute, producing content for books and courses for people, basically trying to be the first and last place of resort. If people are looking for material, whether it exists or doesn't exist, we want to be the place they come to and we can make it happen. We've been partnered with GEMS for 4 years in publishing monthly literature reviews. You can find those on their website as well. We've got 4 years of those in the bank now, and we're continuing to work forward. We're planning on having regular podcasts in the near future to discuss some of these literature reviews with you as well. I'll let Greg talk to you a little bit about his background before we get started.
So, Greg Chapman, I'm really happy to be here live at FDIC 23 in Indianapolis, Indiana. This is kind of a great event here today. Seeing a lot of people that I haven't seen in many years, and made some new friends today walking around the exhibit hall and that. So, really happy to be here. My experience, this marks my 50th year in EMS. I know I look so young, y'all saying I'm barely 35 years old, but 50 years in EMS. I started EMS when I was 15 years old. In beautiful Williamstown, Massachusetts, working for, and you've all read these stories of a combination funeral home, ambulance service, and furniture store. And a lot of you will wonder why the furniture store is in there. It's because they were the woodworkers. They got to make the caskets that the funeral home used after we didn't do necessarily a great job on the ambulance. And that's all changed from what I did back then to where we are now, are leaps and bounds ahead. So my career is, I started off as an EMT and went to college, essentially became a respiratory therapist. Shortly after that, I took a paramedic program in the very early 80s, and that's sort of been my life's mission going forward. 35 years as a paramedic program educator and program director, and I just recently retired this year after essentially 50 years of service, and really enjoying doing a lot of writing and kind of passing some knowledge forward to everybody else that's out there. So I enjoy that. My areas of topics, of course, that I really excel at and I really get involved with is airway management, especially in a trauma patient. Trauma patients intrigue me. They are my favorite calls. I do have some friends who love the endocrine system. All good to them, but
it's a very specific group.
Yeah. when I had to teach the endocrine system, I just hated that. But trauma is where I live. So thanks for having us here today, and we hope to share some things with you. So I guess I'll just kind of kick it off here. One of the things that we have to look at in EMS is, where we were and where we're going, and not to repeat mistakes that we made in the past. And one of the things we can do with that is we can look at research and what's out there. Now, not that everybody in EMS needs to read the research articles. Certainly that would be wonderful if you could read them, but they're complicated. A lot, I'm sure we'll agree that there's a lot of statistical analysis that goes into a research article, and to be able to read research and interpret it correctly takes a long time. Now, I'm not that smart. I've been lucky over my career. I've surrounded myself by some extremely intelligent physicians, and I've kind of turned into a reluctant academic who, basically has learned by osmosis. And I've had this advantage. So looking at research now is one thing that I enjoy. But I can tell you, EMS research, and I'm sure, Will, you'll back me up, of all the level 1 research that's out there, level 1 being the highest grade research in EMS, you can count on one hand the number of studies that are published that are considered level 1 in pre-hospital care. Do you agree, Will?
Yeah, we talked about it in my presentation yesterday that because of the nature of level 1 research, it requires randomization and double-blinded, meaning people don't know what treatment they're getting, one versus the other. Very difficult to do in life and death situations. So we're relegated to doing retrospective analysis, which is looking at all the patients that were seen over a given period of time. And there's problems with that too, because if the paperwork isn't complete, there's going to be holes in the data. So we do our best to get at the best literature to try to give us what our best chances at improving patients' outcomes are.
Right. So before we put you all to sleep, because we're talking about research and statistics and everything else there, let's just sort of jump into some modern topics. That there's some research out there that is trying to sway us one way or another. So one of the first things that I just did a literature review for our group and for GEMS on was chest decompression. There was a good article that was just written that talked about chest decompression for tension pneumothorax. And for a number of years, there's a litany of articles that were written that basically said chest decompression really didn't change the outcome in the field. So, and that's what we look at. We don't look at just I can do a skill, but does the skill that I do provide better patient care and a better outcome for our patients? So it was kind of funny. So I shouldn't say funny because nothing's funny in medicine when people die. But about 6 or 7 years ago, the military looked at autopsies of soldiers who were coming back from the war on terrorism. And they reviewed all of those, and they looked at all the needle decompressions that were done in the thoracic cavity for people who had pneumothoraxes. And one thing that they found was that the needles we were using at the time were too short to reach the pleural space to actually do the job of decompression. The majority of the articles written about needle decompression not being effective were written before that review came out that said our needles are too short. Since then, we've switched to longer 3¼ 3½ inch catheters, which can reach the pleural space. And this new study that came out, they had relatively good research, or as good research as we can get in EMS, unfortunately, showed a 25% decrease in mortality in patients who had their chest decompressed in the field who needed it. So, one of the things is we have to look at research, but we also have to take with that grain of salt. So everything that was written before that, we now can't hold true. Only prospective research from them going forward will change that practice or help put the stamp on that of this is what we should do. This is how we should practice medicine as clinicians in the field.
That's going to be true of anything that we study, too. If the studies bring about analysis that shows that this thing has to be changed, once it's changed, the literature is all going to be new, and the older evidence is only relative historically.
Right.
So, yeah.
I mean, another one that's a relatively simple one is, CPR courses for years, and every one of us out there has taken a CPR course. No matter what level you're at, you've had a CPR course. Well, for years and years and years, back from my first CPR course, and probably yours also, Will, the first thing on the list of the ABCs was airway. It was always airway, airway, airway. We need airway. Without an airway, you die. It was beat into our heads. And God, that took a long time to get changed. And now, essentially, if you're a layperson doing hands-only CPR, you don't worry about the airway. Airway doesn't come into play other than to make sure it's kind of positioned open if you can, but there's no airway management that goes on with the layperson. The other thing is again, our patient assessment model for years and years and years was, for a trauma patient, was A, B, C, D, E. Airway, breathing, circulation, disability, and exposure. Well, now we have progressed to the fact that, and again, we learn a lot of stuff about trauma at wartime. We progress to the fact that, if you're bleeding out from an arterial bleed in your femoral artery, and we don't keep that hemoglobin in your body, and, it doesn't make a difference if you got the perfect open airway if you can't transport that oxygen the airway's giving you. So we've moved to the stage moved to the scenario of, if you see exsanguinating hemorrhage on walking into the room, before you manage the airway, you control that hemorrhage, be it direct pressure, be it, the application of a tourniquet, or be it the application of, an impregnated gauze bandage. So, these are important things, and, we don't want to get locked into just because we've always done it in the past means that we should do that in the future. Does that make sense, Will?
Yeah, and matter of fact, as we've learned these things, for instance, Greg mentioned looking at massive hemorrhage in front of airway instead of ABC. We use a protocol, it's called MARCH, with massive hemorrhage in front of airway, breathing, and circulation. Because it's important to look at statistically what's happening, and these trauma patients die because they bleed to death. We need to identify that and manage it quickly, and we're seeing that this emphasis potentially over the past decade has started to see a change in the way that we even look at the body of people that die from trauma. We always used to describe this trimodal distribution of death that had people that die immediately were a certain percentage, people that died up to 4 hours later was another group that we thought we could do something about, and then finally people that might die days and weeks later. We are seeing now, and it may very likely be a product of the fact that we've changed our approach to our patients, is that the part of the people that died in the medium range is diminishing, and the percentage of people that die immediately is higher, which is just saying the people that are dying died before intervention, and the group with intervention might be even diminishing, that we're getting to them and saving their lives. So much so that they don't even call that intermediate period up to 4 hours anymore. It's 2 hours or less. So the whole distribution of the numbers and percentages of people that die is changing to reflect that we're making some good moves, I think. The deal with looking at traumatic death has a lot to do with your immediate assessment of what's going on and your ability to anticipate what the patient's needs are going to be immediately and long range. One of the things that we've always tried to do is how do you know or how do you identify hemorrhagic shock early enough to be able to make sure that you've cared for the patient adequately. A lot of times people would say, well, you know, you never know until it's too late and the patient starts to collapse on you. And it's not so much that it was a surprise, it was we didn't anticipate. So we're looking at models of assessment that give you the idea that shock is imminent before it happens and which patients might be getting into a hemorrhage problem quickly. One of the things that we're seeing used effectively, and it seems to be affecting change, is called the Trauma Shock Index. This index, rather than looking at a batch of things, just simply has you to take the pulse rate and divide it by the blood pressure. And if the resulting number is less than 1, they're doing okay. If the resulting number is more than 1, they're in danger of hemorrhagic shock or already in.
Is that the systolic?
Yes, I'm sorry, it's the systolic pressure, yes. So you've got a person that's tachycardic and has a lower blood pressure, that number is going to jump up over 1, whereas if the pulse rate and blood pressure are more stable, it'll be less than 1. So it's a quick thing you can do. Divide pulse rate by systolic pressure. If it's over 1, your patient's already in trouble. And doesn't change anything, but what it does do is, along with the rest of your assessment, it telegraphs to the hospital to activate the trauma team, because this person is the next thing they need, besides the fact that you managed the bleeding and got them there on time, is they need to go to surgery.
Right. I agree 100%. And one of the things we need to do as EMS clinicians and providers is to make sure that we use critical thinking skills. I think the educational paradigm that we've used for years, and again, I was a paramedic education program director for nearly 35 years. One of the things that unfortunately we used to do, and I'm sure some places still do, is we teach off from skill sheets. We've always been very, very good at teaching skills. In other words, here's how to do your assessment. I got a check sheet, checking the check sheet, good, you've done that, you've passed. Here's how to manage an airway with a BVM. Check all the boxes, good, you've passed. Here's how to, stop bleeding. Check all the boxes, good, you passed. Unfortunately, what we didn't do is we didn't put all that together and really come up with a way to teach critical thinking for our students. And as Will said, we need to anticipate what's going to happen, and that's that critical thinking. The critical thinking also is like when I said in the beginning, it's like we don't check airway first. We move either to March, for massive hemorrhage, or X for exsanguinating hemorrhage, depending on which mnemonic you use. The big thing there is that if you've got a big enough crew with you, you do it all at once. It's, not just one person down there doing everything. Hey, if you've got 2-3 people with you, one person's opening and managing the airway while the other person is stopping the bleeding. They happen sequentially. They don't happen sequentially. They happen all at the same time, which is really important. Part of your crew management paradigm that you use to manage your crew and make sure people do things at the right time, in the right place for that particular patient. And that's one of the things where we always get ourselves into a little hung up, is that, I hate to keep beating research because, but research sort of drives what we do. Research can be great, but most of our medical research that involves around pre-hospital care truly is done in large urban areas and cities. You know, it's done in Seattle, it's done in Chicago, it's done in Charlotte, it's done in Washington, D.C., or New York City. Well, you know, the closest trauma center is 10 minutes away. You know, that's a big difference from places that, when I started my career working as a paramedic, where we'd have an hour response time to get to a patient in some rural areas, and then we'd have an hour to an hour and 20 minutes, if we couldn't fly them, to get them back to, you know, even just a local community hospital. There's a big difference in your management of patients when you when you're caring for that patient for a long period of time. I mean, if you're an algorithm or a cookbook medic, you run out of your algorithm. You know, you've got to, you know, make sure that you can think about what's happening with this patient, understand it from a physiological basis, and then make those changes that you need going to the hospital at that point. So, you know, but big difference. You know, just because something works in Seattle doesn't mean that it's going to work in Northampton, Massachusetts. Okay, so we have to consider that, and that's one of the big things that medical directors especially have to take into consideration. So, like, if you have an active medical director, they're the ones who are changing your protocols. You know, a lot of places who have more rural areas, they have a regional council, medical directors get involved there, and they change protocol. But you have to think about that. You know, just because it's the newest thing doesn't mean it's best for the patient.
Yeah. So there's case in point, you know, there's a lot of discussions and arguments about advanced life support versus basic life support. And it's important to look at all of it, you know, collectively and not into small, narrow silos, because there are things that we need to do immediately that are very basic, and in some patients have very specialized advanced skills needs. But to apply all of those things with, you know, the same tool is not the optimal way of looking at what your patient's needs are. They should be very simple. I do a lecture at these conferences called Is It Really That Simple? And by the end of the talk, I think everybody agrees that yes, it is. I mean, bleeding can be as simple as direct pressure. It may be as complex as using a tourniquet or using
Wound packing.
wound packing. And other devices that people are looking at. They're working on things for internal bleeding where you can inject material into the abdomen that forms a space-filling polymer that compresses it and stops the bleed. Kind of space age. Results early look promising. There may be things that we can do. But for most of your patients, it's going to be a simple matter of getting to them, controlling the bleeding, and understanding that this is the best you can do and you need to move so that they can get someplace where definitive care can take place. A case in point, again, about how we change and how things over time have... I started as a paramedic also in the 70s and also worked in the emergency rooms at that time. And the common practice then from all trauma codes was to have an IV in each arm and to run the fluid basically as fast as it goes in. You know, speed forward 40 years, and we found out that we're reminded, actually, that the oxygen carrying capacity of IV fluid is 0. So we're in a more passive resuscitation mode now, where we put in enough fluid to give them some support for their pulse and blood pressure, but not so much that we flush out all the red blood cells and pop clots. So these massive infusions of IV fluid aren't doing the patients, it might even make them worse. So we're more passive on that end. On the other hand, in identifying that what the patients need is blood has opened us up to some aggressive approaches to getting blood, whole blood, administered to patients in the field, and we're having some promising results. It's complicated. Blood has to be transported refrigerated. It has to work within the blood bank cycle so blood isn't wasted unnecessarily and that it's preserved properly. It's difficult but not impossible, and there are some early results all over the country that are showing that there is a way to do it. It might be effective, or it will be effective, and there's things look promising that a final solution for delivery of blood in the field might be working its way in.
Right. I mean, one of the problems with blood administration in the field is getting the blood from the blood bank. You know, blood banks notoriously hold blood and don't like to give blood up in emergency situations. And some emergency departments even have problems getting blood and storing it in the emergency department. So it's taking it one step further out, you need to have some really aggressive trauma people and really aggressive blood bankers to, get your system to be involved in a whole blood program. So, it seems simple that blood will save lives, and yes, it will, but administratively getting to that point gets to be relatively difficult. So, and one more thing, going back to what Will said, and we're talking about, again, some research in that. So you old timers out there that are listening now remember mask pants and pneumatic anti-shock garments that were out there. And, your younger guys probably remember hearing about them in school. Well, so there, and what reminded me of it was Will talked about putting 2 large bore IVs in and running them as fast as you can. Well, they did away with mask pants due to one study that was done in Texas that showed that patients did worse who had mask pants applied. And for those of you who don't know what mask pants are, it was like a big balloon that you put around your abdomen and your legs. You pumped it up. And basically what it did, it restricted blood flow to the lower extremities.
It was based on the G suit, which
right,
is a flight.
Right, the G suit. And what it did was it didn't auto-transfuse blood, but it wouldn't let the blood go any lower in your extremities. Well, one study showed that it didn't do any good. So we got rid of it. Now, just like what we talked about earlier, at the time, we were also putting 2 large bore IVs in every single trauma patient, and I was putting them on pressure bags, and I would give 2 to 3 liters of fluid of normal saline before we got to the hospital. We now know that's bad. So my question is, if we restricted fluid like we do nowadays and used the mask pants and titrated to a blood pressure of like 90, would they be a good thing? Because I know, and will respond, we knew we could raise the blood pressure with mask pants. We're probably just raising it too high. And frankly, if you look out there now, if you walk at FDIC 23 here, if you walk through the halls and see some of the medical booths, and especially looking at the tactical booths and the trauma booths, you'll see things like abdominal tourniquets. Okay, inflatable abdominal tourniquets are nothing more than what the abdominal section of the mask pants were. You'll see pelvic binders to basically realign and reclose an open book fracture of your pelvis. You'll see those out there, and mask pants did that when you put those on. So, I mean, did we throw out a product that maybe did some good for us just because of one study that was out there? And then when we figured out it was the normal saline that was actually killing people, maybe we should have redone that study again. And no, I don't have stock in Job's mask pants suits, so that's not in my portfolio anymore.
First of all, a program note. If those of you that are listening haven't figured out, we are live on the floor of the FDIC International Conference in Indianapolis. So the laughter you hear in the background, they weren't laughing at Greg. They might have been.
No, they probably
might not be. Oh, you might hear pipes and drums too coming up. So be ready for anything.
So, another controversy that's kind of out there now in EMS, and it goes back to airway, and we'll move off from airway and ventilation a little bit. But there's a bunch of articles out there that talk about survivability from out-of-hospital cardiac arrest, and they're usually medical cardiac arrests that get measured. Most trauma cardiac arrests, there aren't enough of them to do a good study on. But they look at medical cardiac arrest, and most of the recent studies out there have pointed to patients doing better who are not endotracheally intubated. Okay, now I started off doing endotracheal intubations back in the early 80s, and Will maybe did even before I did. And it was always the gold standard of care to put an endotracheal tube in because they do it in the hospital. They do it in the ICU, they do it in the ED, so why couldn't we do it in the field? And it goes back to that, I was able to do those skills. I could train my students to do those skills. But one of the problems that we have with that is that, when I was working as a medic, I worked in a small area, catchment area, and, in our population area, our catchment area was probably about 15 towns that we'd respond to for ALS. We had 2 paramedic units in town that would handle our city, okay, plus all the surrounding towns when their BLS units came in with cardiac arrest, we'd respond out. And the average paramedic did 3 to 4 intubations a week because we didn't have what I call status paramedicus, which was now if you look at those same towns, all of those towns no longer have BLS ambulances. They all have paramedic ambulances. So your concentration of paramedics has increased dramatically, and your cardiac arrests are still the same. So you still have the same number of people that need to be intubated. The average paramedic in that area now maybe intubates 1 to 2 patients a year. There's a great study that was put out by an anesthesia group that was actually looking at CRNAs and new resident anesthesiologists. And it was pretty good literature, pretty good study. And what it came out to say was for you to be a master of intubation, which we could all agree that if you're doing something for your patient, you should be a master at it, right? You shouldn't be the newcomer at it or whatever. You should be a master at that skill. It said it took 43 intubations to become a master at the skill of intubation.
That's more than a lot of people's career.
Right, and not 43 intubations on Fred the Head or a high-fidelity simulator. High-fidelity simulators are great. They teach great critical thinking skills, but it's not the same as the real anatomy of a patient. It can teach you the movements, it can teach you initially what to look at, but there's a big difference between knowing that that mannequin's going to be fine if you don't get the tube in, and the mannequin, and doing that patient in the OR your first time with an anesthesiologist, or the first time you have to do one in the field by yourself. There's a gigantic difference there.
There's definitely the skill of the ability to maintain skill is one of the things we struggle with in EMS across the boards. I remember one of the reasons I started teaching back in the late 70s, early 80s, was because somebody asked me, do you mind coming in and helping teach skills? And I found rapidly that it helped me to be better at what I was doing when I was teaching people to do skills that I didn't get to do very often in the field. So it made me sharper and that much better. And that's a uniform problem across this. And it's not just in EMS. You mentioned, for instance, the issues with proficiency and intubation and how it's complicated. One of the phenomena after paramedics began intubating was that there were fewer intubations for emergency room physicians and residents to do. And they found there were several articles about a diminishing opportunity to enhance the skill set of physicians working in these departments because the patients were already intubated when they came in. That being said, I think what we're getting at here goes back to my discussion, about keeping it simple, and is it really as simple as it could be? There are simple interventions across the board, whether it's bleeding control or airway management, and one of the things that statistics are bearing out is that the new airway devices that we have that are blind insertions, like combi tubes and LMA devices, these things are very easy to put in, they're very safe, and it speeds up the time of application exponentially. The time it takes to set up and correctly do an intubation without complication, let alone complications, is very different than putting the patient in position, dropping that thing in, done. Right. And there's really good data on patients doing better that are not intubated pre-hospital, but intubated subsequently at the hospital. So people get threatened by this when we talk about being less aggressive, but you're not aggressive if you're using a tool that works and it serves your patient. I would be proud at being proficient with combi tubes and LMAs and seldom intubating. They're great devices, and they're easier to put in, and anybody can put them in. I could train a novice or a house.
I mean, that's one thing. One thing nowadays is that the especially the newer iterations, the iGels, the Kings, and so forth, are extremely easy to put in, and frankly, they're a relatively simple skill. They're not a complex skill. That they've trickled down to first response EMTs on engine companies. Yeah. So the person's getting basically a definitive airway right away. But it sort of comes back to also looking at it as like, is there something else I should be doing before I consider putting in that advanced airway? Even if you look at the Heart Association and you look at NEMSPs, the National Association of EMS Physicians, if you look at their position statements, one of the things that they say about advanced airway management is, that you should look to see if there's other things that need to be done before you move to doing advanced aggressive airway management on that patient. And that comes back to those critical thinking skills.
Yep.
It truly does. It circles right back to the fact that if the patient has a good, open, dry airway, that you can have a first responder or an EMT put a nasopharyngeal or oral pharyngeal airway in, and they can manage to ventilate that patient with a BVM, there may be more things that are more important for the advanced level provider on the scene to do rather than intubate that patient. Certainly defibrillation, medications, making sure compressions are done well. And when that's done, the papers all point to a better outcome for that patient. So not saying that we shouldn't intubate because we're not good at the skill. But I will tell you that there's paramedic programs in the country now that cannot get, excuse me, cannot get the OR time to be able to send their students to the OR because, frankly, anesthesia has moved to the point of where they're only intubating their biggest cases. They're using LMAs. They're using just conscious sedation on a lot of cases.
Yeah.
So there's not a lot of patients that need to be intubated in the operating room, which gives our students and other students, residents in the teaching hospitals and that the ability to get those intubations. So, are we ever able to do that? Now, frankly, if I need to be intubated, I want somebody that's been to the OR. Okay, I want somebody that's been there and at least done, 5, 6, 7, 8 intubations on a live person in the OR. And if they can't, I am more interested in having them drop a King Airway or a combi tube or, an iGel in me at that point because, those minute or so without oxygenation while I'm trying to get that tube in place has been shown to make a dramatic difference in patient outcomes. So, is it a tool in our toolbox that shouldn't be removed? Absolutely. We should have that tool in our toolbox. And that's how I think of airway management. It's like we've got a whole bunch of tools now that we can use for airway management. And as a good critical thinking provider of EMS services, you need to pick the right tool at the right time for your particular patient that you're beside of right now. And that patient next week, or a patient that's like that next week may need a different tool. And that's what you grab.
For years, we worked and wrote and taught courses with Dr. Norman McSwain, who's a famous trauma surgeon from New Orleans, who, not originally from New Orleans, that's where he landed. I've taught with him all over the world, and there were a couple things that he said, I think, that basically lie at the core of this conversation. He would always say what we want to do is to train people to have a fund of knowledge that they can draw from in any situation and apply those things in the right way. And we went about writing, and still write, in a manner that proposes that we think in terms of what we do for our patients as principles versus preferences. Meaning there's more than one way to skin a cat. So for instance, if the principle is to stop the bleeding, it can be as simple as taking a bandage and holding pressure with it with your hand. Or it can be as complicated as having to use a device, to tourniquet somebody off or to wrap somebody's pelvis. It can be more complicated, but it's very situation specific. And the same token, what's the airway solution of choice? The one that works, the one that you're good at, and what you can do the fastest. These patients are critical. They're losing blood too fast. We need to fix that. They're not breathing. Their inability to carry oxygen around the body, even if they're not bleeding, is diminished. We ought to be thinking in terms of what's the thing that I can do the fastest right now, and then we can think about, do we need to do something more advanced or more technical later on? I think these are the type of critical thinking skills that Greg keeps talking about. But the idea is, when we discuss it all, when we think about all of it, when we discuss the literature, not to be a geek about it, but just to point out these things. This is what works, this is what doesn't work. This appears to be a better idea. Simple usually is the right answer because you can do it faster. Right. And you can ramp up based on the needs of your patient and the situation. Some situations, minimally, are going to be so complicated there's only an advanced solution that's going to come to bear. But the vast majority of our patients would significantly benefit from us being faster and simpler at addressing their needs and getting the thing going so that they're where they need to be as fast as they possibly can. And we strongly believe EMTs and paramedics are smart enough to make those decisions. We just have to make sure that we give them the tools and we give them the information about what's working and what the numbers tell us.
And we need to appropriately give them the training, okay? The training piece of the puzzle, to me, again, being a paramedic program director for, so many years, the big thing to me was, and it's a military adage. It's like train like you fight. Okay, so you see programs and you see people going into a trauma scenario in a class, and they don't have gloves on, and they don't have goggles on, and they don't have a gown on. Well, if you get your muscle memory in such a way that you don't do that in training, you're not going to do that when it comes to the real thing. You're going to fight with your gloves. You're going to fight with tape in your gloves. You're going to forget your eye shield. You're going to forget, to put a gown on. So you're going to forget those things. So it's really, really important that we do that, because if you practice, a skill 50 times and you practice it wrong 50 times, have you gained any experience? No, you haven't. You've just practiced something, and ingrained that into your muscle memory incorrectly. So it's important to remember that that trickles down to all levels of training. That trickles down to, your in-service training, at your service. If you're doing hands-on skill stuff, it's a big difference intubating Fred to head, sitting on a table 2 feet high at your, yearly training to prove to your training coordinator that you can intubate, the mannequin. I prefer to have that mannequin sitting on a stretcher in the back of the ambulance. At least it's, a more realistic situation that you're dealing with at that time. And even more so, bounce that ambulance down the road a little bit and see if the person can intubate going down the road. Because that's how we learn, that's how we train, is the way we fight every single day that we're out there.
I think you kind of moved over something kind of quickly that I think is important. We've walked from the clinical side of the skills themselves and then into the training to make sure that we're as good as we can be at delivering these skills. And one of the things that you mentioned was, if somebody learns the wrong way to do it, it's hard to unlearn that. And this is a basic tenet of controversy with instructors. I've been, like Greg, I taught an EMT school for 12 years. I've been a paramedic instructor, and I've been teaching most of my entire life. And I've been involved in many debates about the way you teach people skills and assessment scenarios, et cetera. And one of the things that I used to do I was once corrected was just let somebody go through the scenario, and this is the way most of us learn. Like you would go through this thing and you do this and they say, well, you just killed your patient. And that's how the instructors taught us when we first started. They just let you fail. Years later, I felt strongly that was not the right way to do these things, that it was much better to stop somebody when they're going down the wrong pathway and ask them a question. Okay, why are you doing that? And then, because I'm doing this. Well, that's not going to get you there. And you have a conversation about it when it's happening, so that you have a teachable moment before they go down the road of a muscle memory, badly learned skill, which you're going to repeat easier than what you just learned. It's very important, I think, for us to take that as opportunity. And to your point, a lot of people don't think about that so much, but bad learned behaviors, and because you think you're going to use that to make an example, right, often is hard to get out.
And the debrief at the end is important.
Yeah.
A good debrief should take almost as long as the scenario. And you give whoever is the team leader plus the rest of their crew an opportunity to identify themselves what they could have done better. And then if you're someplace progressive and you have the time, you let them go through a similar scenario and see if they've actually corrected those. And for you Star Trek fans out there, you want to make sure you don't use the Kobayashi Maru. And Will's shaking his head like maybe he's trying to figure it out. So the Kobayashi Maru, for your Star Trek fans, for your non-Star Trek fans out there, was essentially Captain Kirk was talking to Spock, and it was the unpassable scenario, the unpassable event that happened. And Captain Kirk managed to pass it because he cheated on it. But it was the unpassable event, and we should never have those for our students. You see instructors kind of all the time, they'll keep escalating it up until you make a mistake. Well, I can keep escalating it up so that I can take a world-renowned physician and I can make it so hard that they wouldn't pass it. Is that realistic? Is that learning? You should have basically a scripted scenario, stick to that script, and if they do everything correctly during that, they have been successful going through that scenario. It shouldn't be, watch this, I can catch you on this particular thing or that particular thing. There's no gotcha moments. Everything's about learning and about student learning and student advancement.
I'm sure you learned that way too. They used to, like defibrillation, right when you're working on a code in the training session, the instructor would set you up to fail. Like you're there getting ready to hit the paddles, and then he would take your partner's hand and put it on the cart, behind you. And he goes, "You just killed your partner." I mean, this is what instructors love to do. Is like that's the way they learn. That's what they did to us, and it's a horrible example. We've gone beyond that.
It's definitely a bad way to learn. What's interesting now too is I'll sort of shift a little bit here in our last 15 minutes we got left, and I'll sort of move on to
More Star Trek stuff?
Well, no more Star Trek stuff until later on tonight. I think there's a Star Trek marathon on tonight at the FDIC and down here in downtown Indianapolis. But anyways, I'll move on to one research article I just read that was very interesting, and it talked about a third-party app, and there's quite a few of them. I won't mention manufacturer names in here because I'm sure I'll forget somebody and I'll have somebody out to kill me later on after I walk out of this. I won't mention any names, but
we do have to go back to the exhibit hall.
Right, exactly. And the third-party app, what it does is basically anybody in the community who has learned CPR can sign up on this app with their local city, town, county government. And when there's a cardiac arrest, if you sign up and basically say, I know CPR and I'm willing to respond, the app itself through dispatch, through the call center, will identify the closest people to that cardiac arrest, and it'll also identify the location of the nearest defibrillator. So to me, that was very intriguing, and I started looking up, and my local community actually does that. And I signed up for it. Again, there's 2 or 3 out there that I know of that do it in the U.S. But this study was out of Italy, and Italy's done it for a number of years. And their EMS system is definitely different than ours. But what they did was, they signed up a lot of people. They signed up cab drivers. They signed up, the general public in that. And the results were very good with people that would respond to a known or a cardiac arrest that was in progress that they thought of. And it was amazing to, it was a minute or 2 difference when they had responders before EMS arrival, especially in the evening and night hours, which kind of surprised me. I thought it would be the other way around. But especially in the evening and night hours, that you get somebody who would respond and CPR would be initiated before EMS arrival. And certainly there's a lot of research out there that shows that the sooner CPR is initiated, the better the outcome is for that cardiac arrest patient, and you're likely to get more of a return of spontaneous circulation in those patients as an EMS provider. So, it's definitely interesting to think about that. Think about if you can take it one more level down, because I remember when I got in EMS, our first responders were the police department in the area I was. Fire department just did fires. EMS did EMS, and police did police, but they were closest, especially at night and they'd show up. But basically, most of what they did was sort of mark the house that I had to go into and help me get in there because they weren't necessarily trained well. Then we started training them and equipped them with the early AEDs and equipped fire service with engine companies. Fire service wasn't involved in EMS at the time, with AEDs, and we get their responses, and we know that we got better response and better patient outcomes when CPR could be started better. But now we have this opportunity to take it down one more level. Here's a level that I'm sitting here in the bubble here at FDIC with Will, and for those of you who aren't here, you can probably see me on the screen, but basically it's glassed in. There's people outside looking at me, people making faces at me as I'm looking here. I'm seeing friends walking by, and
both of them.
But if somebody dropped a cardiac arrest out there, I'm sure somebody would start CPR. Guaranteed CPR would be started. But I haven't seen where the closest AED is yet. Okay, I know they've got to have them here, but I haven't dinged one on a wall today that said, here's where the AED is. So wouldn't it be nice if somebody dropped in cardiac arrest out there?
No.
Excuse me. Okay. It would not be nice if somebody dropped in cardiac arrest out there, but if somebody did, it would be very nice for me, my phone to ding and go down the corridor 50 feet, and on the wall on your left's an AED, and guide me to it with a GPS map so that they can continue CPR and I can get an AED to save somebody's life. So I think that's the next aspect, is getting civilians involved, both in the use of AED and CPR, and on a trauma aspect, the use of using tourniquets. Because again, I'm starting to see more trauma kits and bleeding kits
In the AED
installed
boxes.
in the AED boxes to deal with not only mass casualty situations, but industrial accidents and so forth. So, and people, while we'd love to have them trained in bleeding control and take a bleeding control course, which I think is important, but pre-arrival instructions by dispatch can also teach them how to apply that tourniquet. They can talk them through it over the phone while they're on there, as long as they know where there is one.
Yeah, I think to your point about it time-wise too, I think the opportunities with new technology is insane. I mean, the stuff that we use our phone for every day, telling us about our own medical condition, let alone somebody else's, I think lots of things are going to happen in the next decade that we can't even imagine. What I'd like to work on to close here is a little bit of a challenge to the audience. For all you guys and girls, women that are doing EMS in lots of different venues, places, types of situations. We've talked about some things today that hopefully help to focus on the simple things you can do to make a big difference in patients that are in critical condition. On your best day, you're able to do that and save a life, and you feel great about that. Other days, you may feel like the patients that you had didn't really need your attention. What I'd like to close with is I think one of the most important things you can do is approach every patient like that was the most critical patient you're ever going to see. Even though it may not be anything that's obvious, frequently they have needs that we haven't been able to identify. And one of the things that we can do is always be professional, always do the right thing, always speak clearly and in a kind and compassionate manner to your patients. And I think in the end, you'll feel better about yourself because you always do that than if you try to section your patients into the ones that need you and the ones that don't. You have no idea how much you can affect a person in those types of situations. You might think that this patient isn't that sick, but in all my classes, I used to ask everybody, how many of you in this room have never been in an ambulance? Or reverse that, how many of you have ever been in an ambulance? Most of them would say no. Okay, so this person called you. That already puts them into a specialized group. You know, most people don't call an ambulance. So regardless of what you're thinking initially, for some reason or another, this is potentially that person's worst day ever.
Right.
And you have a chance to have a very positive effect on that moment in that person's life. And I can tell you from experience, years later, people have come up to me and said, you were the guy that did this when this was happening. And it might not have been a very critical situation, but to that person when they were a child or even as an adult, that was a very, very big deal. And in many cases, changed the way they approached their life afterwards because somebody stepped in. What firefighters do, what EMS providers do all over the world, sometimes even as though I was in the business, I look at what they're doing out there and I think it's crazy that this is what people do for a living. You know, that they'll run in when everybody's running out, that they'll come and get you when you're in an impossible situation. Take pride in that. Always be a professional. Treat every patient like this is the one that really needs you, and you're going to be much happier. You're going to be a great medic, and you'll have a great career ahead of you.
And I'll piggyback on that. I mean, there's sort of an old saying, it's like, it's really easy to do the right thing when somebody's watching, but we really should do the right thing when somebody's not watching. We approach every patient, we may look at that and go, this is an emergency. But to that patient, it is an emergency. You could be their last person that they want to call, but they're out of options. We might go, well, why doesn't somebody just drive you to the hospital? Well, maybe they don't have somebody to drive them to the hospital. We have to have that empathetic tone. And you know what? We all have empathy, okay, especially when we get early in the career. Unfortunately, what happens is a lot of times that empathy gets tangled up in our own post-traumatic stress, and it gets to be difficult for us. So, certainly managing yourself and your stressors. And, post-traumatic stress is a problem on the fire side, the EMS side, and the police side, anybody in public safety. And it's really important that if you're struggling in your career, that you find somebody to talk to. There's certainly identified now enough groups in that out there and enough counseling available that, do it for yourself. Do it for your patient. You know, if you're a partner of somebody who's struggling, and you notice that, you know, talk to them, get them some help. You know, that's a really, really important aspect of care. And I think EMS providers have struggled with more of an issue with that sometimes than in the hospital. So, I mean, frankly, I worked in NICU and pediatric intensive care as a respiratory therapist, and we didn't struggle as much with a death of a child as people do in the field. And I think that's because we were a big team, and we had somebody to talk to about that immediately after the event, and we could talk it out, and we'd spend time together, you know, because we're all there dealing with it. Sometimes in EMS, especially in volunteer EMS, what happens? We have a bad call, we take the ambulance back to the station, and we go home. You know, we're not dealing with, not even sitting across from our partner for the rest of the shift. We're back at home with our loved ones who we don't want to make feel uncomfortable to talk to them about. So I think it's important also that we realize that, and just realizing that it's out there and that it can truly be a career ender for you is really important.
Yeah, so I guess in closing then, to Greg's point there, take care of yourself, take care of your partner. Be the medic that your patients need you to be when you show up on scene, and be careful. We appreciate everything that all of you are doing. We're going to continue to do our work to try to provide every resource that you